Welcome to the Stat AI podcast.
Welcome to the future of emergency medicine, a realm where artificial intelligence isn't just a buzzword, but a beacon of hope and a tool for transformation. I'm DJ Apakama. My co-host Ethan Abbott and I are both emergency physicians, and we have witnessed firsthand the burgeoning role of AI in our field. Our everyday experience grappling with healthcare disparities and social challenges have led us to a pivotal question. In the wave of AI applications, what changes are coming to emergency medicine, and will they be for the better? This podcast was born not just to ask these critical questions, but to seek out answers from the experts, to understand and to demystify the potential of AI in emergency medicine. We believe in bringing this conversation to the wider community to embrace AI as a tool for positive change. This podcast is our exploration of that future, a journey we invite you to join. So let's embark on this path together to learn, to question, and to envision a new era of emergency medicine enhanced by the power of AI.
Hey DJ, what's going on today?
Hey Ethan, how you doing?
I'm good. Welcome to episode 4, which I'm really excited to get going. I think, for our sort of discussion today, we wanted to talk a little bit about this really interesting article that was, I think, published in JAMA Network Open. And it was an article you had actually sent me looking at AI-generated draft responses to patient inbox messages. And I think relevant to today's guest, this is a study out of Stanford. So maybe I'll talk just a little bit about the study and kind of what they did, and then we can talk about our sort of takeaway and maybe some of the applications to emergency medicine. Does that sound good?
Yeah, it makes perfect sense.
So again, this study is entitled Artificial Intelligence Generated Draft Replies to Patient Inbox Messages. This is from JAMA Network Open. It was published March 20th, 2024. And the lead author is Patricia Garcia. So this study, they wanted to really look at how implementation of a large language model could be used to draft responses to patient messages within the EHR inbox. And specifically, the models that they were using were GPT 3.5 Turbo and GPT-4. It's a really well-designed and cool study. So they utilized a prospective single group quality improvement approach over about 5 weeks. It was conducted in the summer of 2023 at Stanford, and they involved attending physicians, nurse practitioners, clinic nurses, as well as pharmacists. And this was mostly in primary care, gastroenterology, and hepatology. And the intervention was to look at drafted replies to patient portal messages that were coming through the EHR and using large language models to facilitate those responses. The primary outcome was looking at AI-generated draft reply utilization as a percentage of total patient message replies, and then their secondary outcomes included changes in time measures, so looking at, did it improve time to completion, as well as some pretty robust clinician experience surveys, which they did quite extensively, and there's a lot of sort of data on that, which we may not have time to go into. So they, in the end, they enrolled about 162 clinicians, and then they had about 73 of those participants who completed the pre and post survey. Again, it was like a kind of wide spectrum of advanced practice providers, physicians, and nurses. Interestingly enough, they found that the mean AI-generated draft response utilization rate was about 20%, and they found there was really actually no change in reply action time. So that was, looking at sort of differences in whether or not it improved the overall time to respond, write time or read time between this sort of pre-test period and pilot period. They did note, I think, and this is maybe going to be a topic that we can discuss, is there were statistically significant reductions in the task load in these pre and post survey metrics that they use to ask clinicians, as well as work exhaustion scores and a few other metrics. So I think it's a really cool study. I don't know. What are your thoughts on it, DJ?
I mean, I think just kind of taking it a step back, this speaks to me on a very anecdotal level. I mean, they have kind of the data to back it up here. But I would be ready to believe this kind of just from kind of a Gestalt type feeling where when we're in the ED, if I'm well, not when we're in the ED, but we're at home using kind of these models like clinically, what I find is that I can use the model and it basically makes it feel easier. It's nicer to do the task, if you want to say, but I don't think that I actually save any time. If I'm crafting a response or even a kind of a document or something, when I put kind of my initial prompt into ChatGPT or Gemini or Bard or whatever, I know that what it spits out, I'm going to have to then kind of take my time shaping, correcting, assuaging it to kind of go exactly the way I want it. And that's built into me. But that process of kind of shaping an output rather than creating from scratch feels a lot better. It doesn't feel so anxiety provoking when you're, trying to sit there and find the exact right word, or you're trying to find the exact right word count, right? Now, these are things that you can, offload to a GBT and make this 250 words or less, and then read that output. I find that, yeah, that whole process probably takes about the same time, whether or not you're using GPT or not. And I'm not really sure whether or not the end product is different, right? Like that would have been interesting maybe to see kind of how patients felt about receiving these automated responses, which wasn't part of the study. But I do know that kind of, again, for me, it does really feel that some of the cognitive burden has been lifted when I'm using these machines. And I really think that's, maybe not a benefit that shows up in time, but definitely shows up kind of in how I feel overall throughout the day. So I think it's a very smart study, is interestingly set up. I hope maybe they do kind of continue to look at these type of things, because I think the applications of LLM in emergency medicine, we're really just kind of getting started, right? And I think a lot of models are kind of at this, well, let's develop some sort of workflow or prototype and see how it goes and try it out. And, I think you were actually saying earlier that a lot of these things haven't, reached the point of external validation yet alone kind of being implemented in a clinical fashion. So you do have to take all these things with a grain of salt. And so I don't want the takeaway from this paper to be, oh, well, AI doesn't work. It doesn't actually save you any time. Maybe the takeaway is that in the future, in the not so distant future, when AI is a little bit better, and that process of me having to kind of shape the output after the fact to get it to sound exactly like myself, maybe that gets easier in the future, right? And maybe that gets better in the future, and we really do kind of start to see those time savings. Because I just don't think AI is going to go away, right? It's probably going to iterate, and we have a chance to make it better or worse. And so hopefully we can continue to make it better, because I think what we're seeing here is a glimpse of kind of that promise that AI can make our jobs a little bit better and not worse. I hope that's what we're saying.
Yeah, I completely agree. I think this is like one of the first studies that really has deployed into the healthcare system. And I think, the sort of the take home that I think everyone was expecting is, oh, it's going to be faster, it's going to be quicker, and all those sort of metrics. But in the end, and the authors really highlight this, it wasn't. The cognitive burden was decreased on clinicians. And that might be, like you're saying, might be where the real sort of benefit of utilizing some of these large language models in the context of, sort of summarization and within the medical record. And so, yeah, I think it's really exciting. It's just exciting to see it kind of in the real world, I guess.
Yeah, exactly. Some actual application. What struck me, even as you were, kind of detailing the study right off the bat, was that this was prospective and not retrospective, which is, I think we get kind of just almost expecting to hear that it's a retrospective derived cohort of some sort. And this is not that. Maybe we're starting to kind of see the next generation of AI studies that it's going to, prove that this is maybe safe in some clinical applications, not all. I noticed that this study wasn't around patient care, right? Like it is and it isn't, right? But if you don't respond to a patient's messages, hopefully they're not putting anything there that's so emergent that something bad happens. Generally speaking, it might be something a little mundane, something that they didn't understand. Maybe you need to clarify. So I think when the stakes are low, it is a good time to maybe try out large language models and see how they work in those domains. But clearly, if we were talking about like missed lab values or missed imaging things, I don't think that maybe that's such an appropriate study just yet. Maybe in the future, in the not too distant future, but at the current time being, I think these are the type of studies we should be seeing, right? These low stakes applications for large language models to help not just emergency physicians. I think this was in general physicians, Brett. And maybe we don't respond to patient messages. You can definitely see how it would be helpful.
All right, so let's jump into our interview with Dr. Dev Dash.
I am so excited today to get to introduce Dr. Dev Dash, who's an emergency physician and assistant professor at Stanford University. He is fellowship trained in clinical informatics and has a master of public health. His research interests include computer vision and natural language processing, and he is also interested in quality assurance and quality improvement in digital health initiatives. Other research projects of Dr. Dash include development of image classification algorithms that help predict hypoxic outcomes. He also worked on the development of a hardware and software system designed to provide real-time feedback about cardiac function at the patient's bedside. We are so happy to have you here, Dr. Dash. Can you just tell us about how you came to do what you do and maybe even why you do it?
Sure. Thanks for inviting me in here. I think I have a very kind of a unique role within our kind of healthcare ecosystem right now. I work at kind of the intersection of clinical operations, artificial intelligence, value definition, and still trying to push the field forward in terms of how do we bring elements from the computer science world into a way that produces value for the healthcare world. So I kind of got here a little serendipitously. I first question I get a lot is like, do you have a computer science background? I don't have a CS background. I don't have any formal training in computer science. Most of my training started in physics. There's a little bit of scripting language work using MATLAB that we did using physics, but not anywhere near like the hardcore kind of computer science bachelor's or electrical engineering backgrounds that a lot of my non-clinical but healthcare colleagues have. And then I was always going to go to medical school. Like I was going to school. And then I initially matched into neurosurgery and then changed my mind kind of about 18 months in when I realized there wasn't enough time for me to do what I wanted to do. And I was really looking for something that was flexible. And EM is like the most kind of flexible specialty. So switched into emergency medicine and I stayed around in the region. So I did neurosurgery at one of the Chicago programs and I stayed in the Midwest at Cleveland, Case Western, to do my EM training. And then towards the end of my EM training, ended up getting an MPH at Harvard just to bolster a little bit more of my kind of statistics training. And a little bit about clinical trial design, which I felt was important going into an academic career. But still, no significant computer science experience. I would say I'm kind of a self-taught Python programmer. And that leads me to the second question I get a lot is, do I need to learn Python to like engage in this field? And categorically, the answer is no, but I think it helps like shore up the vocabulary when speaking to engineers.
I wanted to jump right into some of the questions that DJ and I had talked about bringing up in our conversation. Looking through some of your research, which is focused on computer vision, I think a lot of our listeners aren't really even maybe familiar with the field of computer vision. I wonder if you could just sort of describe it, maybe high level, what it is, and then maybe we can dive into sort of where it sort of intersects with emergency medicine, at least in your research area.
Sure. So, traditionally it's always been the analysis of visual data, and the field has evolved quite significantly over the last 10 to 15 years. If the farther you look back into the computer vision world, the more kind of simpler algorithms you see. So they're very like simple algorithms to do face detection that were developed in like the 60s and 70s and 80s. And then when the deep learning revolution came, a architecture called a convolutional neural network, which is a kind of a deep learning network that maybe not explainable, kind of a black box, but at least it has much better performance compared to humans in terms of object detection and doing it performing at a much faster speed. I would say the definition of analysis of visual elements has changed over time. I was thinking about the question the other day, and the best way I can represent it is if you can put the data on a screen very easily and it's not text or an Excel spreadsheet, it probably qualifies as computer vision. So whether it's photos or videos, or honestly, whether it's thermal recordings or ultrasounds or sonograms, or you want to take the spectral information off of like a sound clip, like that also qualifies as computer vision. The algorithms are best suited for visual information in that sense. So it doesn't have to be a picture, but it has to be something you can represent on a screen that's not necessarily text. So I was very interested in computer vision, mostly because I was interested in the GPU revolution. I started playing around more and more with deep learning. And whenever you start out with deep learning, the hello world of the deep learning is something called the MNIST dataset, which is a bunch of handwritten letters and numbers. And so if you wanted to know how to build your initial program, you would start with this data set and you would learn how to build a deep learning application by training your architecture or your model against this data. And so I thought that's fascinating. You can just like write a number and like a computer can detect it. Well, it's so much more interesting now, especially over the last couple of years. The latest models can tell you what's going on in the scene, which I think is amazing. It's very dependent on the training data that has gone into it. But I think it's super interesting. But the field has also evolved in that a lot of high performance vision models today are not necessarily pure vision models. They're actually mixed models. They're multimodal models. So the one that I think most listeners probably have like easy access to is the GPT-4 vision model. So you can go to ChatGPT and upload a picture of like a menu from a restaurant, and I've done this many times, and have it back engineer what's on the menu and give you a recipe. Or you can go to like a bakery counter and take a picture and like draw something and say, I want to make that at home. And they'll take the picture of the tiramisu and they'll take the label of the tiramisu and figure out like, what's the tiramisu recipe. And if there's like pistachios on it, it'll tell you to add pistachios on it. And so the vision models have kind of merged into the language models a lot, to the point that I actually think a multimodal model is probably part of emergency medicine's future, because as physicians, our job is multimodal, and like explaining that to computer scientists can be a little challenging. But everything we do is like, you go see a patient, you see how they look, you see how they interact with you. That's multimodality. That's vision information over time. You then look at their notes. That's language information. You then look at their EKG. That's like waveform information. That's managed differently. So our job is inherently multimodal. Maybe more so, I think more so than like a radiologist job or a pathologist job. And so I think multimodal models are part of the future. And I remember when I first started my faculty job here at Stanford, my chair asked me, well, Dev, you're very interested. You did a lot of work in computer vision models, but you're interested in moving into more maybe language and more multimodal work. Like, does that make sense? And then she quoted me, like, I thought a picture was worth 1,000 words. Like, why don't you stay in the pure computer vision world? And I told her a sentence is worth a 4K video. And the exact anecdote I told her was like, if I tell you I went into Costco and I got a rotisserie chicken, and then I accidentally threw away the receipt and I had to go dive in the trash for the receipt, and they finally let me out of the store. You see that video in your head, even though I've only said like 18 words. And so the amount of compression that exists in language is incredible. And I think we have to leverage that into our future workflows within emergency.
I couldn't agree more. And that's actually a fantastic analogy there. Could you maybe along the same lines then tell us about your current research or startup work in the area?
So I'm very interested in bringing kind of multimodality to the bedside. What we're doing now is trying to train up multiple types of models, so they all feed into like a downstream prediction test. For example, I'm just wrapping up a manuscript where we've trained up a complex vision model, including that can recognize actors and objects within a scene, meld that information together with activity labels, and tell you what's going on when something happens if one of the 57 activities we've trained against it happens. So, patients eating, drinking, receiving medications, head of bed elevations. We have 57 different activities that our vision model can detect. Concurrently, I'm also working on language models in the emergency medicine space where we can take text, historical text, current text, nursing note, flow sheet information. All of that information is time-stamped. And so we can try to build a downstream prediction task where we feed in a lot of visual information, we feed in text information using a language model, and then we train up something called a foundation model that has general training. And then we can use the outputs of this foundation model for some downstream clinical prediction tasks. So for example, maybe we can take how a patient looks and the behaviors that they perform within a room or a trauma room or as part of a trauma video and take into account their waveform coming out of their Philips monitor device and take into account their medical history and tell us within 1 hour, is this patient likely to be admitted or discharged? Within 30 days, is this patient likely to, follow up as an outpatient or not? And so what I would really love to do and working towards is building the platform that we can help researchers define downstream prediction tasks and make predictions against.
In terms of that specific sort of work that you're doing, I guess one of the questions that sort of always comes up in these conversations, what are some of the barriers that you anticipate with not only testing, but also deploying this in a sort of a real world setting? Like I'm sure this has sort of come up in conversations. How do you sort of envision that? And what are some of the potential barriers to deployment of this?
The biggest barrier to deployment of any model is figuring out the exact workflow and the pain point that we're going to go after. And two, who's going to be your clinical champion? Because I think that whoever's developing and building these models, rarely this is the same person that is the clinical champion that pushes the model forward, integrates it as part of their clinical workflow. So if you imagine, let's take a very kind of an abstract use case where I train up a computer vision models against echocardiograms to do some downstream prediction tests. Maybe it's an ejection fraction number. Maybe it's like how the likelihood that this patient is going to bounce back to the emergency department with a CHF exacerbation, some downstream prediction. Seldom is this team also have bandwidth to interface with the local clinical group to build the workflow and to build that data stream. So it's going to be a cardiologist who works at an outpatient clinic who says, yeah, I'm kind of interested in this. I'd love to take this project on as a pilot at my clinical environment. Who do I need to bring to the table so we can make this happen? What does that intake process look like? The clinical operational folks are very separate from the deep learning researchers who have clinicians like me embedded in them. So finding that clinical champion can be very challenging. And we have a lot of models that have been built up. I mean, like AMIA conferences are full of models that people have developed, and a tiny fraction of them, single digit models across the country ever go into production. And one of the biggest barriers is finding the clinical champion that can integrate it as part of the workflow. Because workflow integration, I think, is 80 to 90% of the battle. I would say that the technical process of getting the data and training out the model against it is, I always tell all my computer science colleagues, 5 to 7% of the battle. Like figuring out how you're going to integrate it as part of your clinical workflow is a big barrier here.
Yeah. And along those lines, then, how do you select a clinical champion? Obviously, you're one case where you've kind of walk in both worlds, but do you think appropriate maybe for our emergency colleagues who are maybe not as initiated in the computer science world or the informatics world to also be champions, given that they are kind of the end user?
Yeah. I think the easiest answer to this, because I think building up talent or like seeking out emergency medicine talent that can do both of these things, interface with engineers and work on the front lines enough that they have a deep understanding of the clinical workflow. Like this cohort is kind of small. Um, and I think that's a much harder problem to solve, expanding that cohort organically. I think it has to be top down. I think institutions have to come and say, I see you're interested in this. You may not have the skill sets currently, but we're going to buy down 15% of your time for you to work on this clinical problem and actually make room for that person in their clinical schedule, chop off a couple of shifts a month so they can start learning these concepts and starting to get integrated and be that clinical champion. I think that's the way. I think that's the faster way of building up this cohort of clinical champions that can build AI tools as part of clinical workflows. I don't think we should depend on our training programs to organically increase this number. And I know residency training programs across the country love MD PhDs or love MD MBAs. But that's just not a sustainable way, in my view, of like building up that cohort.
I've actually been thinking about, and maybe some of our listeners have fears about, is if we have, this is actually coming from the Tesla robot mixed with GPT, which is what popped into my head. And, a lot of the demo videos show them doing quite human tasks, things that, only 2 years ago would have been, maybe unthinkable outside of Boston Dynamic. And now you're seeing, robots that can pick up eggs and talk to you about them. And in that context, what does emergency medicine, how does that coming context kind of change emergency medicine for you? Should we be embracing that change? Should we be standing up and getting ready to fight against the robots? How do you see it?
Those videos are really, really well curated. And anytime I talk to a robotics specialist about this, they always say, it's actually really easy to make a robot do a backflip, but it's harder for them to learn how to jog. And so things that humans can do organically that we have adapted our society to, like robotics is very far from doing well. Now, if they want to pick up an egg, well, fine. I don't think most humans can pick up an egg perfectly every single time, but the robots can do it. I don't see that as particularly impressive, but it's just a narrow task that they do, much like doing a backflip. However, to answer your specific question about what we should do with regards to like ED docs within our field, there is going to be a time where your ability to use these tools will make you so much more of an efficient clinician that clinicians who can use these tools really well will eventually edge out those who don't. We saw a little bit of this with the push from paper to EMR. Fair number of clinicians quit. They didn't want to interface with the computer system anymore. And eventually those clinicians were replaced by clinicians who could use the electronic medical record with ease. We will see something like that with an AI push. My proximal concern is that the push is going to be top down, in that we as a society will employ models, are monitoring physicians on what they do and maybe making recommendations, and then providing guidance to leadership that is ultimately detrimental for the physician at the ground level. That would be my actual proximal concern rather than the robots taking over. I don't think we have any risk of any model taking our job. But we are at a very acute risk of wide-scale automated monitoring that does not produce helpful metrics that may be ultimately harmful for those of us working, in the field, so to speak.
I think that was such an important point and well said that I think we should probably wind it down there. I just want to thank Dr. Dash again. Thank you so much for coming. I think you brought up so many good points and really a great thought process for our listeners to kind of follow, hopefully on their journey through AI as you go through this.
So true. All right, Dev, thanks so much for joining us. We really appreciate your time. And I know you're extremely busy, so thank you again. And we hope to see some amazing research in interesting things down the line from you. So hopefully get to interview you again in a couple of years, and I'm sure the conversation will be even more amazing. So thank you so much.
Thanks so much.
Thanks again for listening to episode 4 of the Stat AI podcast. We look forward to bringing you some exciting and interesting content next month, and hope you get a chance to listen. Thanks again.
Please note that the views, opinions, and information expressed in this podcast are solely those of the individual speakers and do not necessarily represent those of their employers, our sponsors, or any affiliated organizations. The content provided is for informational and educational purposes and is not intended as medical advice. We encourage you to consult with qualified healthcare professionals for any medical concerns or treatment decisions. This podcast is not a substitute for professional medical advice, diagnosis, or treatment. Listener discretion is advised.